Welcome to the Registry Insider. I'm Bill Seifert, CEO and Executive Director for the National Registry of EMTs. And for today's episode, we're going to do the best of, and we'll return to our normally filmed type episodes with one topic after the first of the new year. So for all of you who are working, hopefully you'll have a happy holiday season with your family and loved ones. And for everyone, have a happy holiday season, happy new year, and as always, stay safe. As the manager of the content team here at the National Registry, explain to us a little bit at a high level, what is the exam development cycle, and then we'll kind of get into opportunities where folks can come to the National Registry in person and or virtually and be part of these development activities.
We define that as 7 different steps, and so I'll just run through those steps. There is the first thing we do is we have a practice analysis, and the practice analysis is a study of the practice of EMS. The next step is to develop job tasks and what are the tasks that they do. And then finally, from that, we need to find the knowledge and skills that are associated with those job tasks. And so that is step number 1. After step 1 is done, then we create test specifications. And the specifications to an educator really is a blueprint. We then move it out to a panel, a separate group of subject matter experts, and they review the content of those items, and they give us a thumbs up or a thumbs down. Or if we can revise an item and save an item during the panel, we do that as well. After that, step 4 is then they go out to the test and they're piloted, where the candidates actually experience those items. We do a standard setting where we look at the difficulty of those items and we set cut scores for our examinations. So the SMEs are brought to Columbus, and then they give us feedback as to the difficulty level of that examination, what is competent, what's not competent. And then finally, that last step is we're always evaluating our items as they come on or come down from the examination.
It was very obvious the amount of research that's been done for fire and law enforcement.
Yeah.
And even telecommunications now.
And how much has been done for EMS?
Not as much, Bill, not as much. And when the research that's done for EMS, they're often grouped together. Only 37% of fire services in the United States don't provide EMS. So that is a significant amount of fire services that are providing EMS. And a lot of the times, and I'll just quote what I've heard, you're a firefighter first, you're a clinician second. Always have your fire gear on the truck with you. Police officers, you're a police officer, paramedic, police officer, EMT. And then to do other professions, telecommunications, they often like some type of field experience, not required, but it helps to know what's going on in the field, to answer the phones. Something else that I do, death investigations, at least in the state of Iowa, which is a medical examiner state, and then you have coroner states, it's required to have a law enforcement or healthcare background. So I don't know any EMS clinician, for that matter, that works one EMS job.
The data do support that in terms of the data from the National Registry anyway, in terms of multiple roles.
Absolutely. And so it's with anything else, the more you drive, the more risk you have of being in a car accident. The more jobs you work in emergency services, the more risk you're going to be at being exposed to trauma. And when we don't have anyone offering them help, and even when there is help, data from that I supported in my dissertation shows that it depends on the organization. It depends on the type of environment that the clinicians are in. If they don't have supportive colleagues, if they don't have supportive supervisors, they may still not seek help, even if it's available within their agencies.
Yeah, it's unfortunate, and the reason why I asked the question I did, but how much research has been done in EMS is very little. And how many resources are available to EMS compared to fire, law enforcement, nursing, telecommunicators?
I can't think of a specific one off the top of my head.
That's specific
to EMS.
Yeah, which I think that's the call to action, is to make sure that we, as a profession, as a broader EMS community, get these kind of resources in place, and potentially the concept you have local within your state, how can that potentially be replicated? Can it be? I assume it can be, correct?
Yeah. What I think is more important is doing those peer-based models, but it's developing culturally competent clinicians. And those are licensed behavioral health, mental health clinicians, the social workers, mental health counselors, psychologists, psychiatrists, because when I when I find out that I need help and I go to a clinician that's not culturally competent and I tell them the things that I've seen on the street working as an EMS clinician, they've never heard anything like that before.
Yeah, the level of stress that an EMS clinician deals with in a week is sometimes more than most people deal with in a lifetime.
Absolutely.
So a little bit about the history for NEMT. Obviously, the NREMT, National Registry of EMTs, and the National Association of EMTs, and AEMT, were both founded by Rocco Miranda.
Yep.
Our initial executive director for the National Registry and founder for NEMT. So our organizations kind of come from the same tree, if you will.
Yeah. We celebrate a similar birthday. This isn't EMS in 20 years ago where sort of we just expected people to know what EMS was and know what we do. That's not the case. And I think most people do think we show up, we take you to the hospital. I think we know that that's not what the future of EMS is in entirety. It's going to have to be all these different aspects. It's community healthcare as well. It's this combination of public health and community service and EMS all rolled into one. So having someone that can continue to educate Congress on what we need and what the advancement of EMS is incredibly important. We spend a day on Capitol Hill every year called EMS Day on the Hill, really advocating, meeting with Congress members, meeting with their staff, their advisors, really advocating for EMS. It's a great day. I think everyone knows sort of the iconic photo of everyone standing on Capitol Hill in front of the Capitol. But that's one of the other ways that folks are interested. We take care of scheduling all of the meetings with their local representatives so that you show up, we do a briefing, and then send everybody to meet with the congressional officials and staffers. Absolutely.
Awesome.
I'm going to start actually with the barrier, which is like bandwidth and time, which is, I think, the fundamental barrier we have for everything. When I think about what are the aspects of continued competency, I sort of put them into different baskets. One is, how do I help people maintain competency in these low frequency, high criticality procedures like sick children, bad airways, OB emergencies, right? Things that they may not even see. They'll learn about it in paramedic school and they may not see. And I can reflect on that, right? In my own clinical practice, I have a lot of anxiety about how do I maintain competency in these things that I need to do right the very first time, but I haven't seen in a while. So that's one bucket that we have to think about. How do we track and maintain that for people so that they are comfortable when they're faced and that we are doing our due diligence to support them? Because I think that's our role as a medical director, is to support people and being able to take good care of patients and create a system where they're able to do that. The second, I think, is, things are constantly changing. I'm always faced with what do we do our training on? Because there's all these different things that we're changing. And sometimes I have to still hold back change because I can't just instate all these different things at the same time. I have to make sure that I'm moving people forward as a cohort. And I think as the pace of research, rapidly changes, as our body of evidence is growing at an exponential rate, that also means that we have to be able to design a system where people can grow their practice at a rate that's going to make sure that they are actually meeting the standards of care as things move along. I need to think about how do I make sure that people are competent to take care of all of those things when nobody thinks that actually takes anything special to be competent in, when actually it requires new skills on how do you assess for posterior circulation stroke, how do you properly assess for risks of refusals in a geriatric fall patient and weigh the risks and benefits. So I think that's where the challenge is that it's really exciting because there's all these new things and there's all these ways to this amazing opportunity to continually get better at what we do. We need to redesign the system by which we accomplish that. Because quarterly training with your, sitting in a seat or coming in for skills at a certain thing, I can only accomplish so much by that model. And I'm never going to accomplish what I need to that fits those three buckets. So I think we have to share ideas about how do we accomplish things for those three buckets.
In fact, that was one of the very powerful statements that a soldier in Vietnam at the time had a better chance of receiving care than someone on the American highway. And that was a resonating statement that really called for a coordinated approach to solve this epidemic of death and disability on our nation's highways.
Which actually leads to another fun fact, but that's how the Office of EMS ended up at the National Highway Traffic Safety Administration, was because of the highway deaths that were happening so frequently.
Yeah, absolutely. And, a unique piece of that history. So there's a semi-lost character in history, and Roddy Brands. Mm-hmm. And so he was actually the president of the Ambulance Association of America and lived in Charlotte, North Carolina. Now, he became the first chair of the National Registry of EMTs, which was called the Registry of EMT Ambulances at the time. But he also testified before Congress on the need for a coordinating office. And through part of his testimony, actually, the NHTSA Office of EMS was created.
Yeah. And fast forward to 1969, and the Johnson administration said there was a need for some standardization and uniformity and some national testing, right?
Absolutely. So, wow, what an amazing time. If I could go back and live through that time, Bill, it'd just be fascinating. So you had the American Medical Association, mm-hmm. and the American Medical Association had joined arms with the American College of Surgeons, mm-hmm. and they recognized this issue. They joined arms with the National Institutes of Health, mm-hmm. and President Johnson actually created this commission to look at solving this national issue. And in early 1969, there was this fascinating conference called the Arley House Conference, mm-hmm. that happened in Warrenton, Virginia. And you had all these incredible leaders that came together. You had
luminaries.
Yeah. You had Dr. Safar. You had Dr. Farrington. You had Dr. Rockwood from San Antonio. You had Dr. Eugene Nagel. You had Rocco Mirando that mm-hmm. was there. You had Roddy Brands that was there. You had all these people that came together. And they really collaborated on unifying their vision and saying, how can we solve this issue? And to your question.
So one other momentous thing or element related to the early years of EMS is the Star of Life. Has an interesting history. And I will say the story is often mistold. Share with us a little bit about the real story of the Star of Life.
Yeah, here's the real story. In fact, I look behind us here at the National Registry logo with the Star of Life prominent.
Yeah.
And that's actually very important because in the early 1960s, around 1962, 1963, this is before there was this movement for EMS to really happen. The American Medical Association created the Universal Medical Identification Symbol. Mm-hmm. And it was the Star of Life, not yet called that, but it had a hexagon around it. And they produced this symbol kind of as a medical alert symbol. So they were encouraging anyone with diabetes or epilepsy or other serious medical conditions to actually carry a card with the symbol on it. In 1964, it was adopted by the World Health Assembly as the global symbol for emergency identification. So in just a couple years after that, the AMA actually was building momentum. And this symbol was being associated with emergencies. And they wrote to the DOT and said, hey, let's start using this symbol to designate hospitals that had an emergency room that was staffed. Again, a relatively novel concept in the 60s. Mm-hmm. Going back to our last discussion, when the Presidential Council was formed to actually look at national certification, AMA was the primary driver there. And they formed this new organization, the Registry of EMTs. And this new organization needed a symbol. So the AMA said, this symbol is already getting some recognition in emergency. Let's gift this symbol officially from the AMA to the Registry of EMTs, and it will be exclusively for these new EMS personnel that meet the national standard. And just a couple years later, the registry actually filed for a trademark and was awarded the first trademark with the Star of Life that incorporated that into the symbol that we know today. The EMS Compact is one of many interstate compact agreements. And interstate compact agreements are when states pass a piece of legislation that allows multiple states to come together to solve issues that are broader than one state. And interstate compacts really date back to the origins of our nation. And it's a really unique tool for states to be able to cooperate on areas such as multi-state licensure. One of the most common compacts that a lot of people use and probably don't even know about it is the driver's license compact. So if you've ever driven in a state other than where you live and where your driver's license was issued, that's because of an interstate compact agreement. And so states say, I will recognize your license if you recognize my license. So the EMS compact is really valid 24 hours a day, 7 days a week. Again, just like your driver's license. You don't fill out paperwork. You don't have to ask for a new stamp or endorsement before you drive in a new state. The EMS compact is very similar. Now, when it comes to disasters, disasters typically fall into a couple categories when it comes to EMS and professional licensing.
It wasn't until January 1 of 2013, right, that the mandate for accreditation at the paramedic level took place.
Which the National Registry did,
with the National Registry. So you guys, even backing that up, that were 5 years before that, you told everybody, look, we're giving you 5 years. Think about getting this done or be in the process of getting it done. So a lot's happened since 2013. Here we are in 2024. We started back then with about 220 programs, and we were just shy of about 800 programs right now at the paramedic level. So it's grown exponentially because of that requirement. And I think that's important. So again, I think accreditation brings value. A lot of people are not necessarily sure about what it does, but it does in fact protect the public. It does protect the students. So students are actively enrolled in educational programs at the paramedic level, and
that have met a standard.
Yeah, they've met a standard. The educational program has met a standard, and that benchmarking of the program against the standards for, the resources that they have to be able to do education is really what it is that we're measuring. So we're measuring outcomes like how do they do on the National Registry exam? Do they get a job? And what are the attrition and retention rates of students that enter and then subsequently exit the program? And those metrics are actually U.S. Department of Education metrics. So it's not something that we're making up. It's really what all accreditors in all levels of education have to report.
EMS is the most dynamic and changing profession in the world currently and always has been. So in order to keep EMS clinicians current in their practice, the continuing education program needs to be current as well. And it shouldn't just be a rehash of things I took in my original program.
So the old days of refresher course is not the ideal state? Is that what you're saying?
It's not the ideal state. No, we want innovative, current, relevant, new, something that I'm interested in, not something I've already taken 20 times. Well, as you know, we have a data sharing agreement, so individuals that take CAPC accredited courses can log into their own profile on the National Registry website and hit that import CAPC records button that move over to the National Registry. One of the most important initiatives we have right now is to be sure those records are coming into the CAPC database.
I appreciate the time to talk about the Pre-Hospital Guidelines Consortium. It's an effort that's been actually underway for over a decade now. So back in 2013, the National Highway Traffic Safety Administration, that provides so much support for EMS and for the advancement of science in EMS, collaborated with the National Association of EMS Physicians to create a national strategy that would promote evidence-based guidelines for EMS. And this was recognizing that back from the Institutes of Medicine report, back from recommendations from the National EMS Advisory Council and the Federal Interagency Committee on EMS, all of these bodies were emphasizing that the care that we provide out on the streets needs to be based on scientific evidence. And over the preceding couple of decades, we really had seen an explosion of research that was helping to support the things that we're doing out in the pre-hospital environment.
We at the National Registry, I will tell you, are strongly encouraging educators to incorporate these evidence-based guidelines, both with an initial and continuing education opportunities for EMS clinicians and EMS students. So prehospitalguidelines.org.
So an evidence-based guideline is a publication that synthesizes all of the available science trying to answer specific questions and provide recommendations for clinical care operations. And we systematically scan the literature over the preceding several years to find out what all of the pre-hospital evidence-based guidelines are that are out there, and then rate the quality of those guidelines so we can identify which ones meet National Academy of Medicine criteria for what we would describe as a high-quality guideline.
Okay.
And then we want to emphasize that it's those highest quality guidelines that we think that EMS personnel should really be familiar with, the ones that recognizing that there's now a new EMS guideline once a month published in our literature, even more frequently than that.
From an educational perspective, a continuing education perspective, it's important to make sure that educators, training officers, and medical directors incorporate these within their curricula, as well as within the protocols, ideally. So this is an exciting opportunity for the PGC to kind of, as multiple organizations, push forward and advocate for current practice, evidence-based practice within the classroom, as well as ultimately in the back of an ambulance where we're providing emergency medical services. So very cool.
I think a lot of the basic methodology understanding is where we need to start in the industry for EMS, to include even knowing that there's a certification behind all this to teach in simulation, and it's available.
So what I'm hearing you say, Tim, is that a weekend crash course on simulation is not sufficient enough for an educator?
I would agree. We can start there.
That was sarcasm.
That's okay. That's okay. It's not anything that a 4 hours will get you, but it'll get you started. At least you can give them, some of the tools to go looking. There's a wealth of information out there. I think that's somewhere where we really need improvement. We're doing a lot of simulation. Do we know it's working? And there's a measurement behind it. Do we know it's being done effectively in what we call psychologically safe environment? There are a lot of things I've even felt guilty of in the day, have done in simulation that occurs as a latent error downstream. You don't know that's going to happen until there's a stressful response to it. So we literally do talk about this we call training scars, where this is a negative impact from that simulation. That could be from anywhere from the way we built the simulation to the way we delivered it to the way we debriefed it with the student. So the best practice is to kind of steer you in the right direction, deliver meaningful, impactful simulation that can be measurable for learning outcomes and then downstream patient safety.
You actually need to work through the full 2 minutes. You actually need to work through even things like what happens when there's return of spontaneous circulation, because so much of our simulation stops when that happens. Well, a lot of our patients do get a return of circulation. What do we do then? That's a tangible example of where things have gone off the rails, so to speak, even down to such simple things as, do you use gloves when you're doing simulation?
There's also the notion that simulation involves all this technology. Simulation is not a technology, it's a technique. So good simulation doesn't require $100,000 simulators. It's the immersion that you're using and how realistic that is to what it would be in real life, right, in practice. So
thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications of upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to nremt.org. Thank you very much. And again, stay safe.